Welcome everybody to the autumn webinar of Global Scars Society. And we are really going global at this moment because I heard there were more than 220 people registered from 25 different countries all over the world. So good afternoon to all Europeans, good evening to all people from the East, and good morning to all the people from the West and the States and etc. This webinar, we will invite two important speakers, and the webinar will be about keloids and also about postoperative surgical scars. And we all know that keloids are one of the most difficult types of scars to treat. So we need to understand how the process of keloid formation will be going on, and we have Professor Chao-Kai to talk about that. And later in the afternoon, Professor Ryung will give an outline of the multimodality approach for managing postoperative surgical scars, which are, of course, the most frequently seen scars in the whole world. So just some practical information. On the right, you will see the chat with the comments. There you can put every question that you need to ask, and we will let the speakers answer these questions after every talk, after every lecture. So please be welcome to put your questions there because we want this to be a very interactive session also. Global SCARS Society has always been organizing these webinars, free webinars for everybody. We know that these are always important moments to look forward to. So I'm very happy to welcome everybody. So for now, I would like to introduce our first speaker, Professor Chao-Kai from Taiwan. He's the director of the Genetics Center at the National Cheng Kung University Hospital in Taiwan. He specialized in research for keloids and epidermolysis bullosa, and he will speak now about understanding the development of keloids from the molecular process to the clinical approach. Professor Su, the floor is yours, please.
Thank you. Thank you very much, Professor Peter Moortgat. It's my great honor to attend this G-ScarS meeting and present the pathogenesis of keloid, and it's from the molecular processes to clinical impact. So keloids has been described for more than 200 years. However, the condition has not been fully understood, especially its pathogenesis. And the disease itself, it's derived from the Greek, and it's described the crabbed crown. Clinically, it affects the cosmetic concern and of the patient, and also it may induce the itch and pain, and it's dramatically affect the patient's life quality in some cases. Pathologically, keloids have the two major features. The first one is the tongue-like the advancing age. It's usually in the periphery of the keloid lesion, and usually it's guided by the mechanical stretch. And also the second feature is the hyalinized the keloidal collagen bundles, and it's characterized by thick the collagen. About the formation of keloid, basically it's abnormal wound healing, and as we know that there are three stages of the wound healing, and in the normal wound healing, it becomes the mature scar. However, if it's the pathological scar, there are two conditions. One is the hypertrophic scar. It's limited within the wounded area. And in the keloid, the lesion usually extends beyond the original wound wound area. About the pathogenesis of keloid, actually it has not been fully understood. However, we may divide it into three parts. The first one is the inflammation, and second one is the skin tension, and the third one is the genetics. About the inflammation, there are a lot of the inflammatory cells that participate in the keloid formation. And in the past, it has been reported on the neutrophils, mast cells, macrophage, and Th2 lymphocyte, and dendritic cells. And many cytokines that has been reported to be related to the formation of keloid. And this dysregulation, either upregulation or downregulation, may lead to the inflammation of the including the inflammatory response, immune cell recruitment, or the proliferation, including the angiogenesis and the myofibroblast activation. And today, I would like to focus a little bit on the Th2 immune response. And previously, it's from a group from Kenya and from France. They found that the specific cytokine can be highlighted in the patients with keloid. They performed the ELISA assays on 42 keloid patients and 42 control subjects, and they analyzed the 28 cytokines. Among these, the 28 cytokines, they found some growth factors or the cytokines has been upregulated. Among these, the cytokines, here I would like to highlight the interleukin-4 and interleukin-13. A paper in 2020 by the group from New York, they found that the keloid lesion shows the increased interleukin-4 and the 13 signaling pathways, and they are respond to the Th2 targeting therapy. It's the dupilumab. It has been widely applied for the atopic dermatitis patients. In their study, they indeed found that the Th2 related the gene expression is upregulated in the keloid lesions compared to the controlled or the adjacent the normal skin. And also they show therapeutic response in patients showing it's somewhat like the elevated scar or combined with the atopic dermatitis lesions. However, thereafter, my friends, Dr. Turgan, Michael Turgan, and the Professor Yoni Wito, they found that the lack of the efficacy of dupilumab for the keloid patient. They in total recruit the 70 patients, and they conclude that don't recommend off-label use of the dupilumab for keloid patients. And then an additional patients showing similar additional studies showing the no improvement of the dupilumab on keloid. And we also arranged the same treatment for our patients in Taiwan, and it's a before treatment and after the treatment. Indeed, we did not see any response. And for this part, recently, a group from Boston, they found that the successful treatment for keloid and hypertrophic scar, it's with the systemic and the intralesional dupilumab. It's a 44-year-old female, and they performed the subcutaneous and the intralesional injection of the dupilumab, and showing the more dramatic the improvements by the intralesional dupilumab. Here, I would like to stop here because I think it's a very interesting story. However, we need the more evidence to showing how does the Th2 pathways contribute to the formation of the keloid, or do we have the better drug to inhibit this pathway? So I think this story is still ongoing. The second part of the pathogenesis in keloid is the skin tension. If we observe the keloid locations, we can conclude that they frequently occurred on the tension site, especially on the anterior chest, upper arm, and the shoulder. Also, if we check the growth pattern of the keloid lesions, they're usually showing the butterfly, cracked crown, or the dumbbell shape. They are basically it's the skin tensions the direction. As we know that the skin actually is an organ. Every day we encounter the mechanical force, especially the stress, especially the bending of our knee or the respiratory the movement can have the skin tensions. And also the signaling pathways of the mechanobiology has been widely studied in skin. Previously, we found that the keloid, there are the one important marker is Ryung X2. It's a transcription factor of the bone and the cartilage. It's the upregulated in keloid. And also, it may be regulated by the downregulation of the caveolin 1. It's a cell membrane, and it can regulate the cell stiffness. And we performed some in vitro study to understand the detailed mechanisms of the hyper-responsiveness of the keloid fibroblast to the mechanical stimulation. And for this part, I would like to highlight the importance of the skin tension here is that clinically, the tension reduction technique, especially for the surgery, I would like to appreciate the Professor Ryugawa's effort in showing how could we reduce the tension by the suturing method or the Z-plasty to reduce the skin tension after the surgery, so that the patient receive the treatment, the surgery can have a good therapeutic response. After the operations, the radiotherapy is necessary, and the dose of the radiotherapy is also relevant to the location of the keloid. And the location is basically related to the tension. If it's a high recurrence site, like the high tension area, anterior chest, shoulders, and the suprapubic region, we need the high recurrence. We need the high dose of the radiotherapy for the patient's the status post-treatment. And if it's the low tension area, only one time of the radiotherapy is necessary to prevent the recurrence. So I think the tension is also a very important factor for the keloid formation. And the last part is the genetics. There are very strong evidence or phenomenon suggest the genetic elements to keloid formation. For example, like the pigmented races, like the Asian and Africans. And if we check the family history of our keloid patients, usually they have the autosomal dominance with the incomplete penetrance, the genetic pattern. Also, if we check the twin studies, monozygotic the twin are more vulnerable to have the keloid compared to the dizygotic the twin. So this evidence showing that the genetics play an important role in keloid patient. Also, there are some keloid associated syndromes. For example, like the Rubinstein-Tabby syndrome. They have a very unique smiling face, and more than 50% of the Rubinstein-Tabby syndromes that they have the keloid, even it's a very small wound. And there are two corresponding genes for Rubinstein-Tabby syndrome. They are the the binding protein and the EP300. These two genes, they are the co-activator of the TGF-beta pathway, and keloid-related syndrome suggests that both the genetics or the epigenetics probably play a role in the keloid formation. Previously, we performed a study to understand how does the keloid prone patient to have the unique or distinct wound healing process. We performed the biopsy and rebiopsy study on the keloid patient and the healthy subject as a control. And it's a 3 millimeter punch biopsy. And 6 weeks later, we performed the 4 millimeter punch biopsies at the original site. And we collect the samples for RNA sequencing to understand the transcriptome profiles of the wounds. And we found that in the keloid-prone subjects, they have the more gene dysregulated, or either upregulated or downregulated compared to the healthy individuals. If we analyze these pathways, they can be the Notch pathways, MAPA pathways, or the glycolytic metabolisms related genes. And furthermore, we try to understand what's the unique metabolomic profiles in keloid patients. We collect the 37 keloid patients, the plasma, and also the same numbers, the control subjects. And we found that there are a couple of the metabolic pathways level difference between the keloid and the healthy subjects, including the amino acid level, energy the metabolism, and bile acid metabolisms, and heme oxygenase, and collagen remodeling. And I would like to thank Dr. Alex and Professor John McGraw to guide this study. Overall, these studies help us to understand the distinct features of these keloid patients. However, I think that if we can apply the new technology on our keloid patient, probably we can understand more details for the pathogenesis in keloids. And recently, the single cell sequencing has been widely applied for the research. It's a technique that can examine the nucleic acid sequencing information. It's a transcriptome from the individual cells. It's using the NGS technology. It's first developed by the Gurdon Institute in 2009. And then the first skin research is on the melanoma. And about the workflow of the single cell sequencing on skin tissue, we need the tissue dissociation, single cell enrichment, single cell transcription, and data analysis. And about the tissue dissociation, I think it's the most challenging one because we would like to keep the single cells, they are alive. How to dissociate the tissue, and we need the gentle mix system to dissociate the tissue. And also we need the chemical method. It's enzyme digestion, either use the dispase trypsin carragenase to isolate the cells and individually. And also about the single cell transcription, currently we rely on the oil droplet based single cell sequencing method. It's developed by the 10x system. And then we need the data analysis. It's the huge bioinformatics work to analyze the single cell sequencing data. We need the pre-processing, annotation, and integrated analysis. And so far, there are at least 7 single-cell sequencing studies focusing on keloid. And they may use the 10x system or by other like the G-ScarS system. And about this single-cell sequencing result, here I would like to use a couple of the slides to summarize this result. The first single-cell sequencing data showing the fibroblast heterogeneity. What does it mean? Is that in our skin, the fibroblast actually can be divided into several subgroups. They can be the mesenchymal fibroblast, pro-inflammatory fibroblast, secretory papillary the fibroblast, and also the reticular fibroblast. And in the keloid lesions, the group from China, they found that the mesenchymal fibroblast, they are the major proportion of the keloid fibroblast. And they are corresponding to the extracellular matrix organization, cell adhesion, chondrocyte development, and also it's also relevant to the bone or the osteoblast differentiation. It's somewhat corresponding to what we previously found that the Ryung X2 indeed play an important role in the formation of keloid, especially whether they are the mechanobiology relevant the pathways. I think this one is quite interesting, and it needs the further analysis. And the second part of the single-cell sequencing data showing that the vascular endothelial cells and fibroblast, they have some interactions and showing their how they regulate each other and to have the keloid. The studies that are from the Korean group and a group from Beijing. The studies are showing that the endothelial cells they can regulate the fibroblast and or the myofibroblast and to boost their production of the collagen through the TGF beta signaling pathway. And this information help us to have more understanding of how does the cells, individual cells, play a role in the pathogenesis of keloid. And the most interesting part of the single cell sequencing so far, I think it's the Schwann cell. And Schwann cell has been highlighted in the keloid lesions. And a group from China and also from Vienna, they both found the phenomenon. The conclusion is that the Schwann cell, they may stimulate the macrophage, the M2, and further to stimulate the collagens, the production. So how does the Schwann cells be formed in keloid lesion? Where are they from? And how to reduce the Schwann cell I think it's a very interesting topic. And how to have the translational application. And recently, in my clinics, I frequently applied the 5-FU injection on keloid patient, especially if it's using the tunneling technique. I think it's quite useful to improve the keloid. And here, I would like to use the 1 minute video to show how it works. Okay. Sorry, due to limited time, sorry, I have to skip this. But what I interesting is that the from a paper in 2023, study published in Frontier Immunology showing that the mechanisms of the 5-FU treatment, and they found that the 5-FU can either reduce the FGF signaling pathway, or what's most interesting is that it can increase the apoptosis of the senescence of the Schwann cells, and furthermore, it can decrease the epidermal development and the fibroblast the proliferation. And so, based on this, I think how to have a more new drug to reduce or inhibit or block the Schwann cell pathways, and can we have a further newly developed drug to prevent the formations of keloid? I believe that in the future we will have the more data to show this. And in summary, the keloids can be roughly divided into 3 factors. It's inflammation, skin tension, and genetics. And it's a complex disorder. And the new advancements in single-cell sequencing and the even more new technology is named as the spatial transcriptomics. I believe that they can provide us with the more insight into the keloid, the pathogenesis, treatment, and the prevention. Okay, so lastly, I would like to appreciate the efforts in my lab members, especially Professor Tang and Professor Lee. They are my mentors. And also, I would like to appreciate Professor Ryung. He taught me a lot of the how to treat the keloid, and the team in my hospital, including the radio oncologist, Dr. Xie, and also the plastic surgeon, Dr. Xie Yuanyu and Hong Guoshu, and also my long-term friend, Dr. Cai Jiaxuan from the Chang'an University, and also my mentors for research, including Professor John McGraw and my friend, the Professor Kurt Ru from Northwestern University. So thank you very much. It's my presentation. Thank you.
Thank you very much, Professor Su, for this very interesting talk. Okay, I think we had some questions in the chat. I know that the first question came from Dr. Igor Safonov, and he asked whether keloid scars also form on the forehead, and if so, how often and when?
According to my experience, the keloid on the forehead is quite rare, and but if the patient has a very strong genetic background, I think even on the very soft skin or the very quite the unusual area, it's still possible to have a keloid. For example, like in our anterior chest and upper arm or shoulder, they tend to have keloid. However, if the patient, if they have the strong genetic background, if their family members that all have the severe type of keloid, I think even in their soft skin, they can have the keloid. Back to the questions, the forehead, it's indeed very rare. The location to have keloid. Sorry, I don't have any experience on the for the forehead, the keloid. Thank you.
Okay, then the second question comes from Professor Ogawa. Fibroblast heterogeneity in keloid tissues disappears after steroid treatment. Do you think this heterogeneity is a result of inflammation or a cause of the keloids?
Yeah, it's a great question. The brief answer is that I have no idea. It's a very, very tough question. Basically, we don't know what's the origin of this pathogenic fibroblast. So I think that it still needs more the researchers to solve this puzzle.
Okay, then another question from Dr. Safonov. Can intra-ScarS collagenase injections help break down already synthesized collagen in hypertrophic and keloid scars?
Yeah, it's a great questions. Indeed, in the past, there are some clinical studies using the collagenase. However, it's not widely applied, and I have no experience on this. And probably other experts can provide the more information on this.
Okay. Then a question from Alto Ocampo. The ratio, what do you use as a ratio for 5-FU triamcinolone injection for keloid, and how often?
Yeah, I use the ratio of the 9:1. It's a combined with the steroid. It's a 40 milligram per ml, the triamcinolone. And the ratio is the 9:1. 9 is the 5-FU and the 1 is the triamcinolone.
Okay, great. Then also a question from Ms. Ivanov. Can you please repeat the 3 classifications of keloids? You were talking about tension, inflammation, and the last one was, I thought, genetics. Huh?
Yeah, it's genetics. Yes.
Okay. Then maybe I also have a question because we often also see that hormones play a big role in, they also influence keloids and hypertrophic scars. Is there any new information on that? Because we saw that with pregnant women and with adolescents, keloids showed more than with other people.
Yeah, I think I think if it's pregnancy, I think the hormone can be is a spectating factors for keloid formations. As to the teenagers, I think the skin tension or either the reduction of the hyaluronic acid or the hormones, the issue may contribute to the formation of keloid. One very interesting study on pediatric the keloid patient, they found that below 12 years old, the keloid formation is the possibility is quite low, and after 12-year-old, it tend to have keloid. But so far, actually, we don't know the exact answer yet. But I think the skin tension or the composition of our skin structure, I think maybe it's the reason. But I don't have the exact answer. Sorry.
Okay, then we have a question from Mariana Altomare from Brazil. She's a physiotherapist, so she has a question around pressure therapy, compression forces. Do you have any experience with the use of compression forces to treat keloids and hypertrophic scans?
Yeah, thank you. It's a very nice questions. In my experience, I think the compression therapy is very good on hypertrophy scar. However, for the keloids, I think to reduce the adjacent the tension, traction, the force, it's more important. And I have limited experience to have a good response by compression on keloid. I think it's good for hypertrophic scar, but not so impressive in keloid.
Okay, and maybe the last question before we go to the next speaker from Farzani Ghazemi. Keloid is a fibroproliferative disease. How exactly do you target fibrosis and the proliferative effects separately?
Yeah, it's a very good questions. I think it depends on the stage of the wounds. And once we have the wounds, of course, we need the wound healing. And but if at the remodeling phase, we need to in the keloid, we need to reduce the pathogenicity of this fibroblast, especially this the myofibroblast. They produce the extracellular matrix like the bone or cartilage. So I think the single cell sequencing can help us to understand the feature of this subgroup of the myofibroblast. And I believe that in the future, more studies will show how to target on this myofibroblast specifically. Thank you.
Okay, thank you very much for this impressive lecture, Professor Su. It's good to know that there are now many more possibilities in investigating this keloids and fibroproliferative diseases, especially with that single cell sequencing and transcriptomics. So thank you very much, and hope to see you soon somewhere in the future. Now, I would like to go to our next speaker, and our next speaker is Professor Ryung from Seoul, Korea. Hello, Professor.
Hello.
And she's the chair of the dermatology department at the Gangnam Severance Hospital in Seoul, Korea. She is also specialized in skin cancer, wound healing, and scar management. And her talk will be on the multimodal approach for treating postoperative scars. So the floor is yours, Professor Rowe.
Thank you very much for your very nice introduction of me. It's almost, I think, 11 p.m. here in Seoul, Korea, but I'll try to not sleep and go on with my talk. So the title of my talk would be Multimodality Approach for Managing Postoperative Surgical Scars. And I have no conflict of interest to disclose with this, my talk. First of all, I would like to introduce where I work. I work at Gangnam Severance Hospital, which is at the heart of Seoul, which is the Gangnam area. We have a very good collaboration between the Thyroid Cancer Center, and we have established a wound scar clinic since 2011. And since then, we have consulted around 8,500 post-surgical scars, which equals about 700 patients a year. So today, I will be mostly talking about these patients that I have seen over the 10 years. First, I would like to discuss about what are the most frequent questions that I get from my post-surgical scar patients. They are, well, I have a history of keloid or cystic hypertrophic scar. Will my post-surgical scar become like the ones that I already have? Second one is, why does my scar look different from others? Does my scar need treatment? If so, when is the optimal time for treatment? And if I am going to be treated, how many treatment sessions are needed? So with these questions, the content of my talk will be to kind of classify what these post-surgical scar looks like, also find some risk factors and prognosis of these scars, and last but not least, I would like to discuss about the management of our patients. So an ideal scar is a largely undetectable at the same level as the agent's skin and with the same coloration as the surrounding skin. Well, this is a post-hysterectomy scar patient at post-op 2 weeks and around post-op 6 weeks, which seems quite ideal with a linear, very linear scar. This is another patient of mine with basal cell carcinoma. Most micrographic surgery was done with an advancement flat, and as you can see at post of 5 months, pretty good because we are not, the scars are almost invisible. However, not all scars heal ideally. These are some examples of some unideal scars in a dermatologist's view, some post-thyroidectomy scars, also scars after fracture, and some scars even after scar revision. Postoperative thyroidectomy scars have various clinical manifestations. Normally or ideally after about 4 to 6 weeks, patient presents with this linear, fine linear scars as seen in these photos. However, in a portion of patients, some of them develop hypertrophic scars, some develop linear bulging scars, or some adhesive scars. These thyroidectomy scars can be classified according to the morphology, and this is my classification, and they could be classified as linear flat scar, hypertrophic scar, linear bulging scar, and adhesive scar. I will go on to kind of introduce each one of them. This is a linear flat scar, which is the most common type, and some patients have healed pretty nice. However, some patients have scars due to uneven wound edge closure or sometimes with inflammation. These are examples, some very good examples of hypertrophic scars. This is a typical photo of a linear bulging scars after thyroidectomy. This type occurs usually in elderly women with skin laxity and with tightness on the scar area. Last is the adhesive scar. In these patients, they often complain of discomfort when swallowing, and the scars move with the patient's swallowing movement. So, then how does these post-thyroidectomy scars affect our patients? Our group has conducted a very small pilot study regarding the impact of post-thyroidectomy scars on the quality of life of our patients. Although all surgeons try to make a very small transverse incision line to reduce the appearance of scars, it still causes scar formation in a very highly visible area in the neck, which can lead to considerable problems regarding daily activities as well as cosmetic problems subsequently associated with worse quality of life. You could see in the DLQI scores of post-thyroidectomy scars are comparable to some of the dermatological disease such as vitiligo, psoriasis, and scabies. And this is more acknowledged in highly visible scars with symptoms such as pain, itching, and disturbance of the movement. Among these scars, hypertrophic scars can cause physical symptoms such as itching, pain, and tightness. Therefore, it is most important to discover if there are any factors significantly related to the occurrence of these kind of scars. We previously published a pilot study regarding hypertrophic scar development and found that there are three very important factors that significantly affect the development. First is when the scar is very located near the spinal nut. Second is when a patient has a very prominent SDM muscle and when the patient has a high BMI. These are some examples A, with a patient with hypertrophic scar when the patient has a high BMI, B, with a high prominent SCM muscle, and C, when the scar actually overlies right over the clavicular area. Hypertrophic scars occur more frequently. Recently, we expanded the study to seek other factors affecting hypertrophic scar development and also analyze the prognosis of treatment. And as a result, we found out that young age, male sex, high BMI, prominent SCM muscle, scar located near the sternal notch, and a history of keloids was significantly associated with the occurrence of hypertrophic scar after scar development. However, a history of C-sex hypertrophic scar was not associated with the risk of hypertrophic post-thyroidectomy scars. Among these factors, scar located near the sternal notch and a history of keloid was associated with lower treatment response, which meant that it took much longer for treatment duration in these patients. Next, we are going to be moving on to the management of these patients. As physicians, we all know that not all scars need treatment due to the natural evolution of scar maturation. We also know that the active prevention is more likely to yield better cosmetic results and would require fewer treatment sessions and less expensive scar resolution procedures, but not scars are all preventable. Early detected scars may respond well to conservative therapy. However, in some scars, we all know that multimodality treatment is required. For my patient consultation, I ideally see my patient at post-op 1 to 3 months. These patients are recommended right after surgery to do some conservative at-home treatments such as silicone tips, silicone gel, and moisturizer on the perilegional site. So as a dermatologist, I really wanted to know if through intervention, could we actually make this linear scar more invisible? And if we do something, can we actually prevent the hypertrophic scar occurrence? For cutaneous scar treatment, early treatment would mean to promote optimal healing, and delayed intervention address the established scars. In the wound healing process, I would eventually think the inflammation to around 3 days and cell proliferation to about 3 weeks. So early treatment, in my opinion, is at the time of stitch out or at least until 2 or 3 weeks after stitch out, which is going to be about post-op 3 to 4 weeks. Various studies regarding optimal timing of scar treatment have been conducted. And in my conclusion, in all types of scars, they concluded that it was most effective when the laser treatment was initiated before post of 1 month, which is pretty early in the early wound healing phase. And this was especially true in post-surgical linear scars, not hypertrophic scars. So you could say that for early treatment initiation is most effective in post-surgical linear scars. So through early intervention, could we actually make this linear scar visible? And my answer is that if treatment is initiated pretty early, visible linear scars could be minimized. I would like to show you one of my patients. This is a patient. You can see that there is a very shiny pigmented plaque on her right side of the cheek. As the lesion was very ill-defined, we did a multiple punch biopsy, and the punch biopsy results revealed that the patient had a sclerotic basal cell carcinoma. Mohs micrographic surgery was done to remove the basal cell carcinoma, which required about 5 stages, which left a huge defect on the nose area and the cheek. To reconstruct this lesion, I did a forehead interpolation flap and also a rotation flap to actually cover up the defect, and this is right after post-op. This is about post-op 3 weeks, which is about 2 weeks after stitch out, and you could clearly see the post-surgical lines on her right side of the face, which is not ideal. At this time, fractional CO2 laser was initiated along with the corticosteroid and PDRN injection. This is at post-op 1 month, post-op 11 months. And when we compare to post-op 3 months and about at 1 year, you could see that with treatment, these post-surgical scars that was very evident right after surgery could actually be more improved with early treatment. So for these linear flat or linear bulging scars, I combine various lasers such as carbon dioxide fractional laser and some pigment lasers such as Nd:YAG and vascularization, and also use some injections such as PDRN and for corticosteroid injection to control the fibrosis of inflammation which is associated with these scars. These are some of my post-thyroidectomy scar patients with several treatments. You could see that the scars heals much nicely with treatment. For hypertrophic scar, the main laser that I use is a vascular laser with several injections of PDRN and corticosteroid injection, which the concentration between 2.5 to 10 milligram per milliliter. This is a patient post hypertrophic scar at post-op 5 months, and with treatment, you could see that the lesion healed nicely after treatment. So through early intervention, however, I was only talking about hypertrophic scar treatment, but I wanted to know if we intervene earlier enough, could we actually prevent hypertrophic scar occurrence? I want to show you a very nice study which was conducted by a Korean group here in Seoul at Kyunghwan University, and they actually compare the appropriate timing for thyroidectomy scar using a erbium glass laser and compared when is the most significant time for treatment, comparing 3 weeks, 3 months, and 6 months. And they concluded that the most significant improvement was started when the treatment was started very earlier, as such as on 1 month. However, when you look at the patients, linear scars do improve when they start early. However, even with early intervention, we could see that hypertrophic scars still remain. So, through early intervention, could we actually prevent hypertrophic scar occurrence? For me, I don't think so yet. I don't think full prevention is possible due to multiple factors, which I have shown earlier, causing hypertrophic thyroidectomy scars. However, I think early treatment may reduce the number of treatment sessions required to actually get this done. I want to show you another patient of mine. This is a patient who showed a very typical linear scar at post-op 1 month. You could see a little bit inflammation that is a little bit of warning sign. However, you can see that the scar directly lies on the sternum mass, and at post-op 5 months, you could see that the hypertrophic scarring is becoming visible. Also, the patient has a very strong SCM muscle, which did not help with the treatment, leading to a prolonged treatment until the hypertrophy and erythema resolved. Last, adhesive scar. In my experience, laser treatment was not at all effective in resolving the adhesion underneath the skin. Therefore, subcision was used. Subcision is a very common procedure called subdermal undermining using this kind of Norco needle. It has been widely used to treat acne rolling scars. And we found out that the combination of surgical subcision and intralesional corticosteroid injection is actually a very cost-effective and minimally invasive treatment for these kind of patients. Subcision was performed to cut down the underlying adhesive fibrotic band, which shows pretty good results. So, Last but not least, I would like to conclude my take-home message with all the questions that my patients asked at first. So the question was, I have a history of keloid cystic hypertrophic scar. So if I have will my post-thyroidectomy scar become like the ones that I already have? For this question, if the patient has a history of keloid, there is a very high possibility that he or she will have hypertrophic scar. But although if this woman had cystic hypertrophic scar, I could say that you don't have to be too worried about your thyroidectomy becoming hypertrophic. Second is, why does my scar look different from others? Because scars have various morphology, and in my classifications, they could be linear flat scar or a hypertrophic scar, linear bulging scar, and adhesive scar. So, does my scar need treatment? I have I have said that not all scars need treatment. However, there are scars that need treatment, such as hypertrophic scars, linear uh, hypertrophic scars, and adhesive scars. If so, when is the optimal time for treatment? Optimal time for linear flat scars to possibly reduce, even make it invisible. I believe that early treatment, starting at post-op 2 or 3 weeks, is the most possible good way to actually treat these patients. However, for hypertrophic scars, even though treatment is initiated early, I don't think hypertrophic scar is fully preventable. And last is, how many treatment sessions do I need? This is the most hardest question that I can answer to my patient, because I always say that scars are all different and all the patients respond differently. So we'll have to see how long it takes as we go on. With this, I would like to acknowledge my team at Yonsei University College of Medicine, Gangnam Severance Hospital, who helped me collect all these data and also treat our patients from Thyroid Cancer Center. With this, thank you very much for your attention.
Thank you very much, Professor Rowe, for explaining a lot about the type of scar that we don't always see, but that is very frequently, has to be treated very frequently. The fact that you don't always see it is, I could have been one of your patients because I had a thyroidectomy 2 years ago. And just to acknowledge your basic regime, I did apply silicone sheets during the day. I did apply gel during night and moisturizers in the perilesional regions. And yeah, as you can see, the scar is almost invisible at this time. Okay, so let's go to the questions from the audience. The first question was from Professor Ogawa again. The worsening of keloids is influenced by estrogen, the hormones I was already talking about in the former presentation, but could there also be a correlation between hormonal imbalances related to thyroid disorders?
These are very good questions. I do there is, I do experience that there is a correlation between hormonal balances and thyroid disorders. However, I'm not sure how this will affect their scars. You'll have most of my patients are at their 30s or 40s, and most of them are women. But I do see a portion of male patients with scars, but for now, I don't see that much difference in the scar quality or any kind of imbalance, but there is a association between hormonal balances related to thyroid disorders. I'm not sure if this was a very good answer.
Okay, thank you. Next question is from Mariana Altomare. In your experience, how to differentiate hypertrophic scar from keloids without histology? So, like just looking at these scars.
Well, I think the extent of the scars, as written in the textbook, if the scar is right at the site of the incision areas, I would regard them as hypertrophic scars. However, if they overlie the lesion with the initiative cause, they are more likely to be a keloid. Yes.
Okay.
Mhm.
And next question from Randa Safe. Is there a general rule when you decide the parameter you use when treating hypertrophic scar using fractional CO2?
Well, for this question, for hypertrophic scar, I don't use fractional CO2. Usually for fractional CO2, I usually use it on a linear scars. And for hypertrophic scars, the main modality of laser treatment is vascular laser in my clinic.
Okay, then maybe I can go on with the lasers. You talked about early intervention, about an erbium glass laser. Would you recommend indeed for early interventions in the first few weeks more the non-ablative lasers and the vascular lasers instead of the ablative lasers?
It depends on what kind of scar it is. If the scar has a very strong line, I would recommend a ablative fractional or a non-ablative fractional laser. In my clinic, I mostly use ablative fractional laser compared to non-ablative fractional laser because my patients are usually Asians, and with non-ablative fractional laser, when I use at a very high energy, I experience a lot of post-inflammatory hyperpigmentation, which I don't want. And for hypertrophic scar patients or scars with much more erythematous portion than the linear scars, I would primarily choose a vascular laser for my primary modality.
Okay, thank you. Uh, Now we talked about lasers. Do you have any experience, or would you also advise to use microneedling?
Uh, I have micro needling by yourself or micro needling RF fractional lasers. They're kind of different, but for scars, I would not recommend microneedling because of the risk of increasing the inflammation. Would that be a
Okay.
good? Yes. Hmm.
Uh, then, because with microneedling, nowadays it's also possible to add, yeah, topical drug delivery with microneedling. So would
Hmm.
that also be an option?
Uh, that could be a very good option for me, I think, for any kind of acne scars. However, for post-surgical scars, due to I wouldn't recommend it for post-surgical scars because all the suture materials and other possibilities of other inflammation and infections with the procedure.
Okay, thank you. A question from Marjorie Brook. Have you followed up the laser treatments with manual therapies?
Well, I think that's a very good question. However, in Korea, in my clinic, I have no experience in any kind of manual therapy or physiotherapy, so I cannot answer. I don't think I have a good answer for combining the laser with manual therapies. But I think it
Okay,
will
and
be
that's
possible if the timeline is different.
okay because, yeah, in our center, we also, after the laser treatments, in the meantime, between two laser sessions, let's say,
Mhm.
we do advise the patients to follow scar massage
Mhm.
to, yeah, to make the scar more supple. So,
Mhm. I do
and
agree with
that,
it, but I don't have any experience because we do not have any kind of physiotherapy sessions in Korea, unfortunately.
Okay, thank you. And that's also an answer to the last question, because that was a question about your view on the less invasive techniques such as manual therapy, but also silicone sheets. And I think you gave the answer already in the beginning, that silicone sheets is one of the first line preventive therapies after thyroidectomy, of course.
Mm-hmm. Oh, I do think, as I told you, silicone sheet is for my patients something that they do. That's a very good um, basic treatment that I recommend to all of my patients.
Okay, we're out of questions. Thank you very much for this very interesting talk again. So now it's time to conclude and to start our weekend for some of us already. I think we can conclude that there are now more and more new options to follow up on the process of keloid formation and to know more about this process, like the single cell sequencing, like transcriptomics. And I think Professor Rowe also gave a very good overview of the possible treatments for thyroidectomy scars, which are not always that easy to treat. So I would like to thank everybody for being here. This the video of the presentations will be available on the YouTube channel of the Global Scar Society. If you are not yet registered on that YouTube channel, please do so. There was also a question from somebody if there is a possibility to distribute the reference list. Uh, Especially for Professor Zhu. So maybe we can ask him, and we can also provide this to every person that attended the webinar. Thank you very much. Have a nice weekend, and I hope to see you all again in our next webinar. Thank you.